Thanks everybody for those introductions. It's exciting to see Illinois so well represented as well among the group. In today's talk, we're focusing on baking in response and recovery into our disaster planning. Here we are in what really do seem to be the last days of the pandemic of COVID, while COVID is probably going from being something that's pandemic to endemic. And is an idea for all of this. We are never going to be more prepared for the next pandemic than we are right now, nor are we more at an advantage as far as having the idea of being ready for a pandemic, the next one, whenever it comes, 100 years from now or 5 years from now, than right now. What's likely, if these really are the days that we're going from being in a pandemic to being endemic, is that 6 months from now, we won't be talking about COVID nearly as much, nor will the lessons that are fresh in our mind be quite so fresh. So let's go from a big pandemic where we've lived through response and are beginning to do recovery, and think about preparedness for a much smaller issue. Some of the hospitals represented on this echo by all of you include smaller community hospitals where one critically ill or injured child really may pose a disaster in that it overwhelms, the care of that child overwhelms the available resources. I'm going to take it even a step further. There are many healthcare educators on this call, and healthcare educators often have familiarity with simulations. When we go back to simulations, a step away from patient care, 2 steps away perhaps from a disaster, we're never more at a place where we can learn and think about response and recovery than from, during a simulation than when we're going through a debriefing. So every opportunity that we have, like this has been a difficult set of lessons to learn during the pandemic, but it's an opportunity to be ready for the response and the recovery for the next pandemic or the next single child who's critically ill or injured. So I can see on my screen that I can control the echoes slides. And unfortunately, when I click, it doesn't seem to be responding. Ooh, that may have responded to me. I'm going to assume that it was. I don't have any relevant financial relationships with manufacturers or commercial interests. I've been very fortunate in that a lot of the work that I've done has been sponsored by both HRSA and HRQ, as previously mentioned. The objectives for our talk today are first to have some shared understanding of a set of terms: preparedness, response, and recovery. There are figures that are part of this talk that'll kind of show how these fit together. And I'll even take it a step beyond that and say that it's possible to be doing all 3 of these all at once during a disaster, thinking about all of our shared experience during this COVID pandemic, where there's been secondary preparedness for the next wave. After Alpha, we needed to be ready for Delta and moving forward. And response, different cities, different states have had their peaks of needing to respond at different times. And recovery has been a process that for children has been in fits and starts throughout all of this, and something beyond the scope of this talk that could easily fill up an entire echo session would be the behavioral health consequences, where recovery has been in fits and starts. So our other objectives are to talk about reasons for incorporating response and recovery into disaster planning. Just like we learn from simulations and educational opportunities like this one, we need to look beyond the disaster and think about how we're going to gather information about how we responded, think about how we're going to recover, and how that can help us be even more prepared and ready for the next time our office, our school-based health center, our hospital, our healthcare system, or our state faces a disaster. Our next objective is to look at strategies for when recovery isn't textbook, unexpected surges, whether it is the need to cover for an unexpected gap in the pediatric emergency department, or when it's the resources for an entire state being overwhelmed and there needs to be mutual aid that comes in from adjacent states or territories, or the federal response from disaster medical assistance teams. And then we're going to look at ways to capture these lessons learned throughout recovery. So there's a line that runs through all of this. In our preparedness, we need to think about how we're going to be ready for recovery. What modes will we use to capture our lessons learned, either in real time or soon thereafter, so that when it's October of 2022, and hopefully COVID is a fading memory, we've been able to capture those hard-won lessons. So moving forward, here's those shared definitions as we work our way through. If we think about preparedness, it can be an organization as small as the Cicero family or as large as the federal government. There's a need for risk assessments and a thought of what sorts of natural disasters might happen in New Mexico. How do they differ from Illinois or Connecticut? There was a reference in the chat a little bit ago about 80 miles an hour in the snow. Not sure about the details there, but New Mexico is a place that, for what little I know of New Mexico and the few times I've been able to visit the beautiful state of New Mexico, is it really depends on where you are, what time of year it is, what elevation you're at. You could have an avalanche, you could have a drought, you could have heat emergencies to which children are more prone. So thinking about what do we need to be prepared for and doing a risk assessment. And this sort of preparedness does all the things that you see on the slide. It's a way to do primary, secondary, and tertiary prevention, and also to facilitate short and long-term recovery. Preparedness, whether we're talking about Boy Scouts and other types of scouts learning to be ready, or we're talking about a well-tuned EMS team that does pit crew CPR, people are going to perform to the level that they practiced and they planned. And moving forward, we want to determine which disasters are most likely. So there's the process of hazard vulnerability analysis, and this can be applied to healthcare systems and also to communities. One more piece before we leave preparedness behind is the interplay between public health and public health organizations, healthcare delivery systems, when it comes to children, places where children gather, schools, daycares, other places where children spend time outside of their families. And then develop the plans that we've already discussed. This talk, throughout all the banner that you see on the bottom, is somewhat AAP centric. And the AAP is a source for a wonderful array of preparedness resources. A lesson learned from Hurricane Katrina, when many children were evacuated from New Orleans and Louisiana in general, apart from their families, is the need for family reunification and family tracking. There are other resources that are here on the slide. The AAP is a great resource. Another resource that I'd like to draw your attention to that's been around for about 6 months now is over my left shoulder. And that is, we take a look at the logo there, we have a caped child who's taking us to the Pediatric Pandemic Network. So a resource that I'll encourage you to visit either now or when you next find yourself doing planning for preparedness, response, and recovery is the Pediatric Pandemic Network, an initiative sponsored by HRSA that draws together a network of networks and is already a great resource for best practices and educational interventions. And over the life of this 5-year project, our ambitions are to be the clearinghouse for educational and best practice resources and getting ready for children in disasters, caring for them and helping them recover. So let's build some more definitions as we work our way through. We've talked about preparedness. Now let's talk about response. Here we can see the aftermath of a hurricane and emergency assistance for casualties. The response phase is perhaps the most familiar phase for people who work on the front lines of healthcare, whether it's the response to COVID and the surge of patients, whether it's the immediate response to the all too common tragedy of a school shooting, it's the initial care, decreasing the risk to responders and to children who are bystanders on the scene. And even now, even in the response phase, decisions made on the scene can influence how children and their families will recover. And then the activities that are part of response are all here. Some of these activities are very much public health, the declaration of a disaster. Heck, that's done by who? A governor, or that's done by a mayor. And then mobilizing emergency personnel and equipment. That can be done by an EMS agency, that can be done across a health system, that can be done across a state, or again, at a federal level. An important thing to keep in mind when we think about response is the boots on the ground and the available resources and the available training that are there locally for the numbers that are often shared, something like 72 or 96 hours in a natural disaster. It'll only be a local response. A meaningful federal response really depends on how accessible the affected region is and whether there's an ongoing danger. So the resources that are there will be what's there on the ground for a while. I'd also like to tip a hat to the non-governmental organizations that often already have a presence in a region. I'm thinking of, for example, among many great organizations, the Red Cross, who often are able to mobilize and evacuate and provide safe shelter before there's even a federal response. And I'd like to thank the person who put the link to the Pediatric Pandemic Network in the chat. It looks like the chat is a lively place, and thank you for sharing there. Now, a third definition, as promised in our first objective for this talk, is recovery. This is a way to support families and children as they go through the resumption of post-disaster time. It almost seems like there's a bit of a debate whether we are returning to normal, building back better, learning from the lessons that we've all lived through during this pandemic. Recovery can take a long time. If we're talking about some of the things that affect a child's timing for recovery is their personality, whether they have previous psychological or behavioral health disorders, what their personal loss is from the disaster, and their proximity to the disaster. For example, if the child in the red and black shirt is watching something on television that may be a tragedy in the Ukraine or in a city far away, even if he doesn't have personal loss, if a person is exposed again and again, it creates kind of a false proximity that can make it such that someone has a long recovery phase. As somebody who was in elementary school in the 1980s, I still have stark memories of seeing the explosion of the space shuttle, the Challenger, exploding again and again. And that's not something that would be done now as far as wheeling in a television and having students watch it. We've learned from past responses that response drives recovery. What are the phases of recovery? We're going to take a look at the timing of a disaster. And this gives us a sense, as we go through this figure, you could think about something like a tornado. You could think about a car crash, which for a family could be a personal disaster. You could think about the experience of all too many children in Ukraine right now, how the threat of either bad weather or Russian forces mustering on the border, leading to the heroic response by the people of Ukraine to defend their territory, or the heroic response of EMS and bystanders to save people, leading to a period of a sense of loss, disillusionment. Perhaps there's been a personal loss for a family that was in a car crash, loss of ability, loss of life, loss of agency, and then the recovery phase, which can be pockmarked with intrusive thoughts, bad dreams, reliving the event for years to come. And there are some predictable patterns for this, but of course, every individual's response to a disaster will be different, will be individual. So looking at incorporating response and recovery into our disaster planning, how do we bake all these elements together so that our planning will be effective? We need to consider all of these aspects. We need to think about, when do we trigger a warning about the weather or about a threat of perhaps violence. And where do we have the threshold for that? We need to be sure that from a public health standpoint that there are alerts that push out to people's phones, for example, if there's a high wind warning. This happened recently in New Haven. But we also need to not cry wolf. There needs to be a threshold and a thoughtful way to baking that in as far as the response in our planning. When will we declare a disaster? Who will declare it? What are the thresholds and the criteria for it? Just like hitting the blue code button on the wall of so many hospitals, where it's not a bad idea to do it if you're thinking about it, and then call for help when you need it or when you might need it. Similarly, perhaps calling for a disaster assistance or disaster resources to be staged beforehand. And what are the resources that are available? How can evacuation be done? And the education needs and response of personnel, are those being met, and are people ready? One thing about disaster education, people might be doing a Project Echo about disaster response in March of 2022. The response to their next disaster, might happen a few months later, or it might happen years later. And there's a need for both the initial education followed by punctuated re-inoculation, and then just-in-time training when people know that they're going to be responding to a disaster. And then how do we notify the public? And thankfully, cellular telephone networks have allowed for more streamlined notification in recent years. I'm going to back up the bus just a little bit. I was a little jumpy there. So here we have a framework for response, and this is a cartoon that is loaded with information. Let's start with the explosion that says disaster occurs, and we'll kind of work our way through the cycle. This is preparedness and response. This is, first, every one of these shapes in here is improved if the preparedness happens. I'm going to invite you to use your eyes to walk through it. I'm not going to walk you through each one of these boxes, but each of these is an aspect of preparedness. And the more thought that's been given to it, or at least if some thought has been given to each of these items and how they fit together, then the response will be more attuned to bringing together resources, both state resources, local resources. You see, first we see local, and then county, and then state, and then federal, and how all of this is done, and how the request for assistance from a governor prompts the federal response, the president's response. And ideally, if all of these agencies are using the same language and the same preparedness vernacular, their response will be complementary rather than duplicative, and that it'll be as efficient as possible. We can think of examples where things have gone well and other examples as well. So to think about when disaster recovery isn't textbook, when we have a plan, how do we practice the plan? Do we do tabletop exercises within our hospital? Do we pull in schools? Do we pull in, the superintendent of schools office in our community? Do we bring in EMS? And how do we maintain it and make sure that it's not merely a 76-page binder on a shelf somewhere, but it's something that's a living document that has job sheets and has ways for people to stay focused. We want to have, if you're in a pediatrician's office, or if you are a school nurse, having an office disaster kit that starts with communication and essential supplies. And then a need to think about the facility. Where are there opportunities to ensure that medical records are kept safely, and also ways to have some safe duplicative work. On the business side, on the finance side, often in hospital readiness, we talk about the FLOP, which stands for finance, logistics, operations, and planning. The finance side makes it very important as far as having insurance coverage and having our total team have a test of the disaster readiness. And then that there's a shared mental model regarding the sorts of disasters that can occur. I can see Dr. Bullard-Barrett sharing the famous quote, which I believe is everyone has a plan until they get punched in the face. I may be paraphrasing a little bit, but it could also be everyone has a plan until there's a novel coronavirus that is shutting everything down. More about baking in response and recovery into the planning. Here are some practical strategies that you can use, in your healthcare organization. Having service and evacuation plans really makes a lot of sense. What do I mean? How is EMS going to get to children who may be ill or injured in a disaster, or if there's a need to evacuate a school because of a tornado warning, how is that done? Or do people shelter in place? Maybe that makes more sense. And then depending on the sort of disaster, infection control, personal protective equipment, business continuity, especially for general pediatricians, but not exclusively. We all know that critical access hospitals and community hospitals across this country are often threatened. And during this pandemic, a number of them have shuttered their doors. So, business continuity is a real consideration for smaller and community hospitals. Thinking about our own safety and preparedness planning, what we know from surveys of nurses, pediatric surgeons, and others is people are more likely to respond if they feel prepared and trained, and if their own families and their own pets and everyone they care about, they know that they're safe. So having a preparedness plan for a home. Vaccine issues have certainly been part of what we've lived through in this pandemic. And then thinking about connections with a hospital. Whether you're an EMS agency and having shared drills for what happens when there's a mass casualty event, or you are a pediatrician's office who is getting ready for disasters and having a backup plan should your building be compromised or your ability to deliver care be compromised. There's been a lot of talk recently about compassion fatigue and the trauma that providers have after chronically delivering care to people who've been ill for a long time. And certainly in pediatrics, the issue around so many patients during this behavioral health crisis that's been part of the pandemic for a variety of reasons. Recovery takes time, but having some plans to collect data, to promote recovery, these don't happen by accident. They need to be part of our plan. So, whether we're talking about psychological first aid and being sure that we are working with our staff and with our teams and with ourselves to look for signs of burnout, and when possible, building in time for people's wellness. When it comes to families, getting an understanding from family members and from parents, knowing what's typical for a child in a crisis event can help us know whether what's happening for the child in front of us represents something that's pathological or it's in keeping with the child's personality. Because we have to understand too, from a behavioral health standpoint, that often we're seeing a snapshot that is may or may not be reflective of the larger psyche for the child and what the child's needs may be. And again, if we don't ask, we don't know. When it comes to planning for unexpected surges, whether you're an EMS provider or not, it's important to have an understanding that when there's a scene with multiple child and adult victims, there will be primary triage done on the scene. It's not the point of this talk for everyone to feel comfortable doing primary triage. For some members of this group, it is appropriate. And for others, it's important to just know that the most ill and injured will be tagged or designated red. Patients who are unable to walk that have normal vital signs will be category yellow. If you find yourself as a triage officer in the future, one of the best ways to start is by using a loud voice, asking everyone who can walk toward you to get up and walk toward you. If people don't do that, that can mean a lot of things. It can mean they're injured and can't walk. It can mean that they don't hear. It could mean that they use a language other than the one that you just communicated with them. But everybody who can walk toward you probably doesn't have significant illness or injury that needs to be addressed right now. Patients who are obviously without signs of life are tagged as either black or blue, depending on the triage system that's being used. And another important piece here is that pediatric patients, for people in EMS who often are doing this triage, don't represent the majority of patients they see. In fact, for EMS, something like 1 in 20 or maybe 1 in 10 patients. I know that New Mexico is a relatively young state, meaning that the average age is younger than in a lot of other states. But still, only about maybe 1 in 10 EMS patients in New Mexico is a child. And among those children, they tend to not be all that ill or injured. So if we combine a pediatric population with an uncommon or rare event like a disaster, these EMS providers are being asked to do something very difficult when they're asked to triage and make decisions about who gets treated first and who gets transported first. When it comes to office and hospital planning, thinking about all of these factors you see listed on the screen here as far as the 4 S's, but also ways for training for your team. Earlier, we were discussing a video game that's freely available that's really meant more for EMS providers, but may have some value for anyone who cares for children and may care for them in disasters. And that video game link, Catherine, Schaefer, if you'd be so kind to put disastertriagegame.org in the chat, I'd encourage people to visit that and see if it's a good fit for the educational needs of your learners, particularly if you're involved in EMS or emergency care. And there's also resources for surge planning through ASPR, as alluded to. Other questions to consider is, how do we vie for time and resources for disaster readiness in a time when there are so many other concerns for healthcare systems, when healthcare systems are thinking about their future and expanding their scope of care. And ways to do this can be in a very reactive way. After a disaster, is often a time where a hospital and healthcare administration is most receptive to the idea of improving a plan. Ultimately, we want to be proactive in improving our care, but this is a way to work toward buy-in from administration. Other questions to consider, and I apologize, everyone. I wonder if my connection is a bit spotty. Oh, there we are. How to incorporate children into exercises and to test plans. A thought for this, disasters that are mostly pediatric do happen, but more often, every disaster involves children, but there will also be adult victims. So how does your children's hospital or EMS agency or pediatrician's office or local Department of Public Health plan for a mixed population that includes adults with special healthcare needs, geriatric patients, and children, and make decisions about what resources are used and where people are transported, and how children are going to be tracked and reunited with their families? I may just blatantly ask if we could advance a little bit. It seems, although it says I'm able to control it, it's doesn't seem to be responding. So sometimes children are not accompanied by adults, and we need to have a way to keep children safe and supervised so that they don't have secondary injuries or fall victim to exploitation. And also including community partners and in who will take care of in what to do when we have practices who choose not to see patients. Again, thinking about the COVID pandemic, if there are practices that opt to not see patients who have signs and symptoms of COVID, or for the next pandemic, how do we manage that? How will the community response be? So other strategies for capturing lessons learned, another very practical side, are having some documentation of the preparedness so that we have a living document that can be accessed when the disaster occurs. Journaling, like literally journaling for people who work in emergency response, to write down what sorts of events occurred and what went well and what didn't. This can be centralized and be something that is electronic and kept as a record, or handwritten as needed. And then using exercise evaluation teams, even for the real thing. So there's this idea of the Homeland Security Exercise Evaluation Plan, which is a way for communities that stage large-scale exercises or smaller drills within, say, an emergency department. You can use that same resource when the disaster occurs and look at all the inputs and how your response went so that you can think about moving forward to planning for the next disaster and fostering recovery. Having an after action review and even an interim review, as so many organizations did during the pandemic, is yet another way to capture lessons learned and to regroup and do an even better job. So in closing, our goals are to plan locally with the understanding that all disasters are local, while building ties with state resources, New Mexico, Illinois, Connecticut, and federal entities really helps promote success. And baking in the ideas of response, which occurs locally first, and then recovery really is part of preparedness and response. I'll be curious in the discussion, about techniques that you've used, but having plans for surge, for personal preparedness, and for those who are, among other things, business owners and those who own their practices, thinking about business continuity and resiliency. So thank you so much for your attention. Some additional resources are in the slides, which will be available to you as participants today. And I'll turn it back over to Catherine. Thank you.
Hey, Mark, this is Jeff. Thanks again for presenting such a great topic. I've got a million questions that I'd love to kind of throw at you before we kind of talk a little bit about a case, for example. But one of the things that I was really struck by, and for our Child Ready group here in New Mexico, is rural response planning versus urban response planning. And by that, I mean, within our state, because we have one large population center and then the majority of the state being rural, versus East Coast, where you have competing medical centers trying to take direction, just kind of a sense of how the communication differs in a state like New Mexico versus where you are on the East Coast in terms of collaboration and coordination.
Yeah, thanks. That's a great question. One of the things we're kind of fortunate about here on the East Coast is, if I'm working a shift in the emergency department and there's a mass casualty event, there's no question, where the hospitals are within 30 minutes, where critically ill and injured patients can be sent in addition to coming to my children's hospital, versus if we're talking about Albuquerque to Santa Fe, or Las Cruces to Albuquerque, or Las Cruces to El Paso. We're talking about long distances and big stretches of highway where the availability of pediatric certified centers or trauma centers is spotty at best. So I think that there are much greater experts on real lived experience in New Mexico than me. But I think in those situations, it makes sense. This really underscores the need for good preparedness and good mutual aid agreements, transfer agreements, decisions about what level of criticality for a patient or what threshold as far as number of patients against a backdrop of whatever else is going on, and whether it's such a large disaster. New Mexico is a lot of things, but wet, for the most part, is not one of the first words that comes to mind. So, when I think about a hurricane coming up the East Coast here in Connecticut, I would think that perhaps Hartford and New York City might be impacted. I'd turn this around and say, are there natural disasters, earthquakes? Is there a fault line in New Mexico that could potentially impact the large population center or centers? And if not, then perhaps the resources are available so that if that long transport can be done, the receiving facility has all of its faculties and is ready to go. So I think the difference is calling for help sooner and having better communication earlier on when the resources are more sparse. Other thoughts from the group?
Yeah, for me, one of the things I'm always struck at is, well, in certain respects, our planning for the pandemic, it kind of is, Albuquerque centric in that our groups of leaders and physicians and Department of Health, we had more of an ear directly to the governor than I think some of our smaller communities, and trying to make sure that people aren't left out in that thinking and that planning is so crucial. And certainly our Native American population within New Mexico, got ravaged by pandemic issues early on compared to the rest of the populace. And so I think just if nothing else, as you already alluded to, the fact that we've lived through this pandemic, I hope we're a little bit better at reaching out to all of the communities, and that's certainly part of Child Ready's whole premise. You also touched on one of my other big questions, which is disaster is a big word that encompasses a lot. And I think that just kind of that recognition of the approach to a one-off climate disaster or an earthquake versus the slow-moving, disaster of a pandemic takes different kind of thinking and different approaches.
Yeah, you make a good point. When I first got started in disaster medicine a number of years ago now, there's this idea of all victims, all hazard approach. Now, first of all, that word victim has become outdated. It's really all survivors. And then the idea of all hazard. I mean, what a great thing it would be if there was one disaster plan that fit all disasters. But we know that disasters are influenced by their scope, their scale, their timing, how many people are affected, and whether we're talking about rural New Mexico or rural Vermont, we're talking about if you have a minivan full of unrestrained kids who have significant injuries in those settings, it's going to be different than it is in Albuquerque or New Haven or New York City, as far as how many EMS units can be brought to bear, what the transport times will be, the availability of pediatric surgeons, pediatric emergency physicians, and the like. So, your point regarding planning and disaster being a big word, certainly, we've learned that it's more complicated than having an all victims, all hazards approach. And for tapping into Native communities, rural communities, places where there are critical access hospitals, all the more reason for the hubs, the children's hospitals, the large hospitals, the academic centers, the large community hospitals to push out to those folks, and also for those folks to seek connections and planning long before the next disaster happens. And again, I'll kind of repeat this definition, this idea that disaster is anything that overwhelms the available healthcare resources. But beyond that, we can imagine a wide variety of what those look like. All right, to maybe bring to bear some of what we've learned about, we're going to take a look at the case. And you're familiar with this as echo participants. It's a way for us to to kind of unpack some of the events that may have happened in your community, certainly happened in mine during the pandemic. If it's okay, I'll go ahead and talk about this case. So you can imagine Dr. X works in a local community hospital emergency department and is seeing pediatric patients. His friend and colleague, maybe they play basketball together, is a medical director for a healthcare system that includes 10 practices in the area around the hospital. So a lot of the children in the community are seen at these 10 practices. Dr. X has heard that these 10 pediatric practices have just decided to screen patients before they arrive in offices and stop seeing sick patients due to COVID-19 protocols. I doubt much of this is happening now, but it doesn't take too much imagination to think about maybe another strain that comes around the corner in July. And here we go again. So the hospital that Dr. X works for, as an emergency physician at, is working at capacity. There's a lot of patients with COVID, but also there's influenza, RSV, and mental health concerns. So the hospital is strained. The physician practices are not seeing patients who are sick for public health reasons and also for the safety of their staff. So with that being the groundwork, here are some questions for us to consider. The hospital staff has expressed concerns about their ability to maintain services. They're at capacity, they're overwhelmed, and they're having some real fatigue. Dr. X, our emergency physicians, just asked by the hospital administrator to develop a plan that could be put into place within a week. You have 1 week, put together a plan that would improve staffing, coordination of services, not only in the hospital, but also with community partnerships, of which it seems those practices are reluctant to care directly for people who have COVID. Dr. X can identify another hospital representative to assist with the development of that plan and coordination of the care in the ED. So there's at least a colleague who will work. Here are 2 questions to consider. Who can Dr. X choose to help him, and what steps can be considered now in preparing for the ongoing surge? It's a little artificial. I mean, this sort of thing in a hospital might involve a whole committee, and the idea of having a week to turn it around sounds like something that might happen in a disaster. If you want to think about how preparedness might have fit into this and maybe even help avoid being in this situation in the first place, please do. But who are some people, or who is the person Dr. X might turn to? And what strategies could be used by our intrepid team to capture these challenges and lessons learned to improve their disaster planning for when the pandemic is over? So already they've got a lot on their plate. They're at capacity. And how can they capture lessons learned in addition to taking care of this onslaught of patients? So there's our case. I'm curious what you all think.
Dr. Senna, are you still around? Because I would really be curious with your experience in terms of how your facility as the primary care pediatrician interacted with the hospital in the middle of the pandemic. Yeah, I guess Bobby had to take off. So.
Could we go back a slide just to get that background again so people can look at it?
Sure.
Sorry. There we go.
Again, the context here is.
Sorry.
Oh, it's okay. I'm sorry. The context here is basically, if we have a set of pediatricians' offices who are reluctant to see patients with a communicable disease, in this case, COVID-19, and a hospital that then becomes, perhaps there are urgent care centers in the community as well, but a hospital that's seeing an increased burden of patients, of pediatric patients, in an already strained time, what are some ways to tap into community resources and make it such that the hospital is better equipped to care for all these children who might be ill? I'm thinking maybe more along the lines of Omicron, when children were more affected with mild to moderate illness. And then what are some other ways to be sure that maybe not all of the children are cared for in the emergency department, especially if their level of illness or injury is amenable to being cared for elsewhere. when their pediatrician's office is reluctant to see them.
I have to say my knee-jerk reaction is do something to force them to do it, but that does not make for a very good working relationship as things go on. And I have learned that I need to control my knee-jerk reactions. But maybe having some kind of triage tool that would maybe refer the non-COVID patients to the alternative clinics, reducing that load at the facility might be a way of reducing some of the patients that are streaming through the doors, and finding out what the community facilities are comfortable working with,
Yeah.
and facilitating keeping them out of the hospital when possible.
And, you know, so even here at UNM, when the plan was considered and we had great leadership involved, pediatrics is always kind of the afterthought. We're not a freestanding children's hospital, and because the pandemic didn't wreak quite as much havoc on children, at least initially, in terms of death, certainly not, but in terms of illness, we found out, yeah, pretty significant. There was kind of a slow response, or a slower response. And I think those of us who take care of kids had to really advocate within the leadership of the hospital and even at the level of the governor to get that acknowledgement. Dr. Cowdery, I don't know if you're still on with us, but I'm kind of curious, in a community pediatric ED, did you end up taking on all of the community COVID patients? Did they all end up getting referred to you?
Yes, we that's really the case during the COVID season.
Robin, you had a question?
No, I just wanted to comment on, you know, not quite like with the community primary pediatric, but we experienced something very similar to what's discussed here in regards to the school system here in Albuquerque, the major school system here, where, so for example, when they started their testing protocols for all their students on their return to school, they didn't have a system set up. So then all those students were coming to our emergency department to be swabbed, you know, and it was discussion of, well, they're a major school system. How can that be changed? How can they set up some freestanding swabbing clinics? Or how can the schools themselves, you know, the school nurse themselves perform the swabbing as they're sending the child home, and that kind of a thing, as opposed to overrunning the pediatric ER with those swabs and such like that. So that's all I wanted.
No,
yeah, it's a great point. You know, sort of understanding, you know, I think asking more questions can really serve us well here, as far as you know, why the reluctance, or is it a matter of not enough of some resource like PPE or testing kits, or is it training, or is it comfort? Or is it that the person who's being turned to do the tests maybe has some pre-existing medical condition themselves that makes them really hesitant to perform the role that you suggested, Robin, regarding testing?
In, you know, in terms of kind of recovery and moving on, I think the pandemic type of disaster versus an earthquake type of disaster, or what's going on in the Ukraine right now, these ongoing situations that keep changing. And it's so much our nature to want to, okay, haven't we turned the page yet? Haven't we turned the page yet? And so supporting each other in terms of the recovery portion becomes that much more important. You know, I have a huge pet peeve in this situation that hospital administrators across the country haven't understood that they should give all the nursing, all the RT, you know, a huge pay raise to maintain them at your facility, maybe just for 6 months, but that way not having to hire out so many travelers. And, you know, I certainly understand why my nursing staff wants to look at traveling gigs, you know, it makes sense, you know, and so it seems to me like that's part of the planning that hospital administration hasn't kind of figured out, that economic sweet spot of what makes more sense, trying to retrain many new people or keeping, you know, paying the price for retention. And, you know, I certainly advocate for paying the price of retention. Thanks, Robin.
Listen, I second that. Thank you.
So this is Robert Perry. I think one thing to go into your scenario, and it kind of played into COVID, is that we, as hospitals, whether it's a pediatric hospital, adult hospital, it doesn't matter, we're doing a good job in making sure that we're prepared for when those disasters and emergencies respond. For engaging and preparing primary care, whether it's adult primary care, pediatric primary care, we have not done a good job at that. And what are your limitations? What are your, you know, I think Jeff said it, was, is it training? Is it funding? Is it, you know, what are those barriers? And we need to collectively as a nation and engage those primary care individuals and those practices to, one, better understand that, and then two, to help bring them up to a level of preparedness where we've brought at least the hospitals to some degree of preparedness. That, you know, primary care doesn't engage in disaster drills. It's sometimes hard for them to understand what is their role when that happens. And I think COVID is a perfect example of, well, we'll just close our practice, or, oh, we'll just send them to the ER, or when something happens. And that's where we need to take this lessons learned from COVID, apply that back to primary care and say, here's some of the lessons learned. Here's where you can help us out. Here's tangible examples of preparedness activities that you can do as primary care individuals.
Absolutely, Robert. For introduction, Robert really is our local disaster guru here at UNM, and has really been such a vital force in making sure that things have moved forward appropriately. But I also think it depends on which private practice setting you're looking at. A personal example, my brother is a general pediatrician in the San Diego area in a very large medical system. He also has an underlying medical condition. And as soon as the pandemic hit out, they set Mike up as a telemedicine doc for doing the initial screens of all the patients. And that was an institution that was large enough to be able to pull something like that off. I think if you're a solo practice, or 5 people in a practice together, it's a lot tougher to do something like that.
In these situations, allowing everyone on the team to practice and work to the top of their training, is a way to aid the response and ultimately promote recovery, because have the best possible outcomes. Whether it's your brother Jeff, or whether it's allowing paramedics who are trained to manage airways, things will vary depending on who the personnel are and what the needs of the patients are. But ultimately having that baked into the preparedness piece, so that the people are prepared to work at the top of what they're trained to do, and also so that their work looks the most like what they do on a day-to-day basis. For example, if you have an emergency nurse who is really good at taking care of a number of patients simultaneously, let that person do the work of taking care of a number of patients simultaneously during the disaster, and the outcomes will be better than asking them to do a role that's different. And also that'll help sow the seeds for recovery.
Well, I want to be respectful of everybody's time. We're at the 9 o'clock hour. A big thank you to Dr. Cicero for joining us and providing such an excellent topic and review on recovery and response.